the second colloquium for the Work Science Center. Thanks in particular for braving the impending hurricane weather, right? You're putting your lives at risk to be here, and I certainly appreciate it. I think Ruth probably appreciates it, and Ken as well. So the Work Science Center was founded by Professor Ruth Canfer as a common ground, as a foundation for people who are interested in the well-being of workers in the modern workforce, right? It provides a platform, if you will, for people to come together to understand the many different ways that people are influenced by the environments that they work in and respond to social situations that they work in and respond to those and how those responses may change as a function of their lifespan. The way that they respond at 65 may be a lot different than the way they respond at 25, for example. And one important aspect of this is how people operate under various social circumstances that are present in the workforce. And some of those social circumstances are related to interactions with coworkers and so forth, which can be kind of complicated, maybe superiors, people that you supervise, and so forth. But another is how you work in the context of teams, and that's going to be the focus of today. We have, and I don't want to do the introduction for Ken, but we have Ken Catchpole from the Medical University of South Carolina, and he's going to talk about teamwork under high-pressure circumstances. And to do that introduction, I'm going to turn it over to Keaton Fletcher.
Thanks, Mark. Sorry, I didn't notice. I'm Keaton Fletcher, the research scientist with the Work Science Center. And I don't know about you, but I've definitely experienced lackluster interactions with the healthcare system and noticed that there's some room for improvement. And we as psychologists, I think, can offer something and really a solution to that. And our speaker today, Ken Catchpole, really embodies that solution through the scientist practitioner model. He's worked with healthcare providers around the world, including those in Norway, New Zealand, Dubai, Qatar, many others. He's worked at Oxford over in the UK, Cedars-Sinai in California, and most recently he is the Smart State Endowed Chair in Practice and Human Factors at the Medical University of South Carolina. And so he'll be talking to us today, again, about teams in high-tech surgery. But before we begin, on behalf of the Work Science Center, we would like to offer a small or large token of appreciation.
Oh, thank you. I haven't done anything yet. You might want to take it away once.
That's always an option.
Thank you so much. Thank you. That's really sweet of you.
But yeah, so thank you very much for coming. And now, Ken Catchpole.
Thank you. Thank you. Now we're going to talk for about 45 minutes. Great. It's been really fun to meet a bunch of you today and to sort of think about where what we do cross over. I've spent the last, before I start, it's actually really nice to be here at Georgia Tech. My dad was here studying engineering, I think in 1948. And so it's nice for him. He turned 90 this year, so it's going to be nice for him to, it's always nice for me to talk about. Hey, I'm coming to talk here about what I do now. But the second thing is, I spent so much time with clinical, with clinical teams thinking about clinical problems that my background in sort of human factors and ergonomics, it's sort of stuck probably somewhere in the mid to late 90s. And so talking with the stuff that you're doing from a sort of more researchy theoretical perspective today has been really great for sort of fueling how I'd like to think about some of this in the future. I'm going to give you an impression of why that is and why both things are complementary and necessary as I go through this. I think my talk is really in sort of thirds, one of which is about working in healthcare and what healthcare is like. The second piece is really about some of how I started to think about doing work in surgery to understand surgical teams. And the third piece is really, how that's led me to think about how we can start intervening to make changes that might improve things. So I guess it's in thirds. I think the other piece is, if I get too jargony, stick up your hand and say, hey, jargon alert or something, just stop me. Otherwise, we'll probably be, we can have questions later. I get to talk to clinical audiences about human factors. So it's really nice to talk to academic psychologist audiences about clinical stuff. So this is my background. I did my PhD in the psychology department at the University of Leeds. Sat in the back of an ambulance looking at how drivers respond to ambulance sirens, which was kind of fun. Then went into the defense industry. In 2003 started working in healthcare, firstly at this children's hospital in London, then at the University of Oxford at the John Radcliffe Hospital, in 2011 at Cedars-Sinai, and since 2016 at MUSC. So all of these things, so one of the things is all of the stuff I'm going to talk about, I can fairly confidently say isn't just about the places that I've worked in. These are fairly universal problems. I've consistently found that in what I've published and where and the people I've talked to. It's amazing how consistent the problems are. This is why I'm here, because medical error, whether you believe in this headline statistic or not, it affects an enormous number of people every year. The quote here, and it depends on what you define as a medical error, and it depends on a bunch of things, but it says, it's the third leading cause of death after heart disease and cancer. So we can debate that, but the truth is that an enormous number of things go wrong in hospitals all the time, with often actually mostly unnoticed, but often with catastrophic consequences. And so this is my goal in life. And I think it's probably my goal in life, is to stop unnecessary deaths in hospitals. And the way I'm trying to do that is through the application of human factors expertise to healthcare. It's relatively new. When I started in 2003, there were very few people in the world doing this. There still aren't that many people in the world doing this, but there's a lot more than there were. Through experience, evidence, and return on investment, how do we make it clear that thinking about teams, for example, is going to make a difference to a clinician who really has never had to think about teams in their life before? It's about whether their patient survives, gets off the table, and for the cheapest amount of money. And it turns out that publishing case studies and teaching about this is a good way to do this. So I came to this actually the other way around. I didn't necessarily intend to be an academic or strict academic. It actually turns out to be a really, really good way to do this. And one of my aims in life is to get a paper in the New England Journal, which is the most respected clinical journal, I think, in the world, with the title Human Factors in it, based on some way in which we've used human factors to demonstrate to the thousands of patients we would need, that it benefited the thousands of patients that we would need to get in the New England Journal. Because that will legitimize the sort of research that we're trying to do within the hospital environment, which does not necessarily see this as being a legitimate thing to be studying. And I'll get onto that, I think, in a minute. So there's there are sort of epochs of patient safety, how this has turned out. So the sort of interest began in 1999, in sort of 2000 in the UK, with a report called To Err is Human that actually said, hold on, we're actually killing loads of people, and this isn't about bad people, this is a systems problem. It must be a systems problem because different people are dying for the same reasons all over the US, and actually, hey, all over the world. So it was the start of this idea of let's look beyond blaming clinicians to really understand what the environments in which clinicians are working. So the second thing is, well, let's do what they do in other industries. And so this was the sort of, this lasted until, 2010, things like checklists. Oh, well, they do this in aviation, surely it's going to work in healthcare. Well, okay, this isn't working so well, or rather, checklists sometimes work and sometimes they don't work. We don't understand. This is a whole lot more difficult than we thought. This is something that I tend to hear about a lot, low-hanging fruit. These are things that so obviously, that we should obviously be able to fix. Well, if they're so obviously fixable and they have such an impact on patient safety, then we would have fixed them already. So low-hanging fruit, there are easy fixes do not come about easily. They can occasionally, but actually that's usually because you've done a lot of work to unearth what's the underlying problem. But I think this is where we are now. We've got to do much more to understand what we're doing and how we implement stuff over a big organization, not just an organization, but over our entire health system. So it's one thing to have, people in this area doing simulation or using checklists or doing briefings, but actually it's a very, very different thing to have multiple hospitals doing that effectively in multiple places, not least because every operating room, every ICU, every emergency department is different. So I also wanted to address this idea of other industries, because I think it's an important one. There's been a lot of talk about, aviation model. Well, most of the other industries, certainly in which human factors has been applied, or industrial engineering, were technology mediated. There's a big, you're flying an aircraft, or you're operating a nuclear power station, or you've got a big aircraft carrier. They are often engineered in the last 150 years. They have very clear goals. They usually produce. We choose to do them. They're usually well-resourced, and the evidence is commerce-driven, and they're usually complicated. In other words, if we press the right buttons, there are loads of buttons that we need to press, but provided we press them in the right order and at the right time, we'll generally get the outcomes we expect. Well, healthcare is none of those things. It's predominantly delivered by humans. There aren't an enormous number of technologies that healthcare practitioners use that separate them from the patient. If I'm going to give you an injection, if I'm going to give you a drug, if I'm going to, all of those things are, by and large, still require human beings. It was never engineered in the first place. Nobody ever sat down and said, hey, how do we engineer healthcare? So it's sort of grown organically, which means that a lot of the way in which the system works is really opaque. Nobody knows how it works, and actually it's kind of difficult to work out how it does work. One of the only ways in which we often understand how the healthcare system works is when it goes wrong, and we realize, oh, that's what we rely on, and we didn't realize that. And I'm gonna, you get the idea, but this is another one, conflicted and unachievable goals. If we get better at curing these people of this, then we're just going to have them come back with comorbidities. They're going to be more complex when they come back in 5 or 10 years' time. And by the way, we're not going to solve the problem of everyone dying. So these have actually a massive impact on how we understand safety and error. Because if we don't know what our goals are, and we don't know, and the raw materials that are going in other words, our patients, we don't know about that, then we can't very easily define the transformation process and whether that was right or whether that was wrong. So that's why there's some stuff we can learn for other industries, but lots of which we can't. And making this distinction is a really, really important one. So, yeah, I'm not going to so, yeah, that's that. Okay. So this was the biggest payout. This is the most, this is tragic accident, was the biggest payout in UK medical legal history. The accident happened, basically this poor girl got brain damage. In this operation, there are 2 syringes, one of contrast, which helps to look at the blood vessels in the brain, and another which is essentially glue, which is going to be used to block some of those blood vessels in the brain. These 2 got mixed up, which gave this girl catastrophic brain damage. So the report says this accident happened when 2 syringes got mixed up in the operating theatre because they were not appropriately labelled. And to go on, if the syringes had been marked up so the hospital could see which contained dye and which contained glue, then Maisha would not have suffered what is an utterly devastating brain injury. Such easily avoidable mistakes should not happen. You see a lot of this in healthcare. It's garbage. This is the sort of low-hanging fruit idea. And I know that because I was in that unit working with that operating team 18 months before. And in one of and I've done a lot of hanging around in operations. I'm going to talk a lot about that. So this is a neurosurgery operation where it's called a VP shunt. It's basically a tube that goes from a little hole in the head to relieve pressure on the brain down. It drains fluid down into the stomach. So basically you drill a little hole in the head and you put a little hole in there and you pass a tube under the skin all the way down there, and it basically it relieves pressure in the brain. And in this particular operation, there were 4 people at the operating table when normally there would be 2. So there was the surgeon, and then there was actually a senior surgeon who was sort of mentoring the other attending surgeon. And there were 2 scrub techs, one of whom was inexperienced and one of whom was new. And the new one was being trained up. So you've got 4 people at the operating table when usually there would probably be 2. And as often happens, the operation didn't immediately proceed smoothly. Due to equipment problems, the diathermy, or the BOVI, is the electrocautery device. It cuts and cauterizes at the same time. It's a very, very commonly used piece of instrument. It didn't immediately function. It probably wasn't turned on. This happens a lot. And the cranial drill, which was pneumatically powered, somebody had clamped it to the drapes and occluded the pneumatic line. So during this operation, there were all these scrub techs on the floor trying to pull apart the drill to find out why it was working. And then somebody said, "Oh, look," and took the clamp off the drape. Oh, okay, we worked out why it's not working. This sort of stuff, by the way, happens all the time. If you think this is just about the NHS, it's not. And the surgeons were struggling with the equipment. It was an inappropriate size for the patient because the management had said, "We don't want you to work in that operating room, your normal operating room. We want you to work in this operating room." It didn't have the equipment they would normally need. So this sort of unawareness that the administrators have about the impacts of their decisions on the clinicians is a huge issue. And so, with all this stuff going on, it kind of creates turbulence. We could think about, I'd love to sort of think about how we could apply better models to understand what this sort of turbulence means. But essentially, there's lots of stuff going on, and as all this stuff is happening, the inexperienced scrub nurse is getting asks from the 2 surgeons, and in doing that, it accidentally gives a previously used syringe of local anesthetic, which is called Cairo Pain. So local anesthetic is used at the incision site to numb it. So I talked to a number of anesthesiologists, and I have conflicting views about Cairo Pain and its effects. What I understand is that if it comes into contact with the central nervous system, it's catastrophic for the patient. So if we're using Cairo Pain down here, we're about this far from thinking it's saline. We're about this far from killing the patient. And Fortunately, there's a scrub, the experienced scrub tech says, no, stop. You've got the wrong syringe, don't do that, and the error was captured. So this was a syringe swap in that operating room that could have been catastrophic 18 months beforehand. We were actually doing a team training intervention there, which didn't work very well at this particular hospital. So, but beyond that, it was this really just a labeling problem. And by association was the other one really just a labeling problem? I suspect not. I think there's lots of stuff that we could look at that would give us a better way to understand these types of incidents. And that's what I'm all about. This, I wanted to throw this in. This is a sanitized version of one of the incidents we had at MUSC, just to demonstrate how complex the interaction between all these different pieces of the system is, and how they all interrelate. And I'm seeking ways to understand this better, and I think we can. I'd love to think about some of those things with you. So the other piece of this is a nice little way to think. That's called workers imagined versus workers done. Have you come across this idea? Okay, so this comes out of Eric Holnagel, who does a lot of resilience engineering within, which is sort of branch of human factors. So workers imagined versus workers done is exactly this. The workers imagined is, your organizational diagram. Workers done is, well, how we interact every day. Workers imagined is what you think goes on in an operating room. Workers done is what really goes on in an operating room. Workers imagined is saying, if only the syringes had been labeled, then everything else had been fine. Workers done is being in that operating room and looking at all the ways in which errors can happen all the time. And so this is workers imagined. That's what a manufacturer of operating room equipment thinks an operating room looks like. It is unlike any operating room I have ever been in, anyone's ever been in, and probably will ever be in. I don't think there's going to be an operating room that ever looks like that. That's more like it. It's at least full of real equipment. And you can see how cluttered it is. That's getting more like it. This is actually a cardiac surgery, and you can see the huge numbers of people, the equipment, all the stuff that's going on. You can imagine how noisy and busy this is. And then these are some of my own photos about operating rooms across a bunch of hospitals that I've worked in, both in the UK and the US, some of them of whom who have the highest reputation of being the best hospitals in the world. This, by the way, is a $1 million piece of equipment that to get it in the room, firstly, the room isn't big enough, the operating room wasn't big enough, but to get it in the room, the nurse has to go down on the floor and pick up the power cables so that we can move this $1 million device underneath it. It's also battery powered, and at least in one operation I know of, it wasn't charged up and the batteries ran out halfway through. All right. So workers imagined versus workers done. We've got what we think, how we think the system works. You can understand how this goes down with clinicians. It kind of blows their minds. But so the ideal is, we have protocols for this. Well, protocols don't account for all eventualities. That's something you'll hear a lot of clinicians say. They should have done this. Well, we ask people to not do what they should do, but we ask them to be adaptive, flexible, efficient, innovative. All the stuff around violations is very interesting. There's a form of industrial action called work to rule, which says that we're only going to do what it says in the rules. And so we rely on people to break the rules to get this job done. So saying that they should have done this doesn't necessarily reflect what we ask people to do every day. What's another word for innovation? It's breaking the rules. It's taking shortcuts. And so we need to, So anyway, evidence-based is a big thing in healthcare, but it's very rare. And indeed, the interesting thing about about evidence is it's not behaviorally motivating. That one of the things that I've had to do is go out and demonstrate, because surgeons were saying to me, prove to me that, that teamwork makes a difference to my surgeries. And so I was like, okay, well, let's go out and do that. And then you go out and present that, and they say, oh, well, no, that's not my surgery that applies to. That's all those other people's surgeries. It's different from my sort of surgery. And indeed, of course, evidence ends up being quite socially constructed. An example of this is that in the in the UK, to avoid infection transmission, we ask the physicians and nurses not to wear ties and not to wear anything below the elbow, because the theory is that you're there over a patient, your tie goes onto the touches the patient, picks up an infection, and then you go and do that and you transfer it to the next patient. Now in the US, we have white coats, and they love the white coats, and they have ties. So we don't have even in something fairly straightforward like infection control, there are very different approaches to how we do that. And so the evidence that we base it on, we base those things on, is in a way socially constructed. And training and policies. Administrators, when something goes wrong, love to write a new policy. Well, policies are unknowable. You can't know them all. Unknown, I didn't know there was a policy for this. Unavailable, well, I need it now, but it's on a computer somewhere, or it's on a, it's in a, or it's unrealistic. It's 30 pages for a 5-minute, 5-minute part of my job. So this is the difference between workers imagined and workers done. And this is the area in which we're trying to work to understand how we can improve the work that's done. And this is my favorite human factors slide. I've shown to hundreds of people. Fumbling for his recline button, Ted unwittingly instigates a disaster. Wings stay on, wings fall off. This is what we do to our clinicians. And years ago, in fact, about 10 years ago, I was presenting this slide, and and an anesthesiologist said to me, oh, we've got a wings fall off button on our new anesthetic machines. This isn't that machine, but this is a similar idea. This is the main dial you'd use to change all the different settings to get the right displays on an anesthesia monitor. And it's right next to the on-off button. Now, there's no reason why it needs, there's no reason why it needs to be there. It could be there, there, there. But you can imagine you're an anesthesiologist, you've got a patient here, you've got the monitoring there, and you're worried about the patient, and a lot of good anesthesia is still about touching and feeling. And so you're, or at least, observing. So you're observing the patient, and then you reach up to change something on the monitor. You switch off all the monitoring. This is suction, which is, this is the on-off for the suction. This is the on-off for the anesthesia machine. So as a design solution, we've put a nice little plastic cover on this one here, so that people don't make that mistake. Or what do you think is more likely to happen? Somebody going to think, oh, why is there a plastic cover on the suction power button? This stuff is all over the place. This is my final story about this. This is a bone injection, interosseous injection device. It's based on the principle that if you can't get IV access, then you can get medications into a patient who needs them quickly by firing off or basically putting a needle into the bone marrow that will get then, which will then distribute those drugs. And this one is a spring-loaded device. It's about so big, I think, and that's what it does. So anyway, I was talking, so I had a resident phone me up one day and said, yeah, I wanted to talk to you about this thing that happened. I went to a crash, and the usual stuff happened. There was lots of uncertainty. The nurses were slow to, I arrived, and then when one nurse arrived, and then, then the rest of the team was slow to arrive. Anyway, there's lots of stuff going on. And so we worked out this guy, we couldn't get IV access. So we said, right, okay, well, let's get the IO device out. So the nurse unpacked the IO device and gave it to me. And then as I was sort of preparing to use it, I looked and I saw that the patient had a below knee amputation. As you can see, it's usually used in the lower leg. So he says, right, so I put down the device and I found the appropriate spot and elsewhere, picked up the device and fired it off. Unfortunately, I got it the wrong way around. And the needle came out the back of my hand. And he said, I just don't know. I obviously I didn't see the big arrow on it. I'm so stupid. I was like, no. This is 100% and absolutely a design issue. It feels the same whichever way round it goes. And there are other devices like this, which is actually, it doesn't fire off, it screws in. And it's a pistol grip. So you're not going to make that mistake. So you 100%, that 100% was not your fault. And this was a new sort of idea that in a way that clinicians are taught that it's all about them. Whatever they're given, they deal with it. And so to say, no, you were totally set up to make this mistake shouldn't be happening, there's no need for it to happen, you were not at fault, is a very, very new idea. It's one of the reasons why a lot of these bad designs still exist, because the clinicians don't know that they're being set up to fail. All right, so that's, yeah, I need to, so this is the stuff that I've sort of been involved with over the past, so all of those are those are stories, and which sort of illustrate, I think they illustrate one of the challenges is, right, how do you turn this into science that's going to make publications that are, it's fine for me to get up and talk about these things, and I think that, that's part of the point, but how do you spread this and how do you make a science out of this? And so these are the projects that I've been involved in over the past 15 years to try and look at some of these things. And this is sort of my pathway through it, and how a lot of these pieces are connected. There are some other pieces that I haven't included. I'm going to be talking about a lot of these today in one form or another. The red boxes are the ones that have been interventions. So a lot of these have been about, right, what's the problem? Either analysing databases or hanging around in operating rooms, trying to work out, right, what are the problems here that we need to be solving? And then these are all the studies that I've tried to look at. How do we, if we try and go about solving them, what happens? Because it's one thing, it's easy to write a paper that says, this is the problem. I recommend that we should do this. And human factors is full of this. But that's not what's going to help us solve the problem. And indeed, of course, it's easy to write a paper that has recommendations in. It's very, very difficult to have those, to apply those recommendations. It's even more difficult to measure then an improvement as a result of those recommendations, and even more difficult to get that published. Because when you send that to a publisher, they're like, if it's just a problem thing, it's like, there isn't nearly as much attention to method, you don't have to describe the intervention, and the measures there isn't nearly as much scrutiny as the measures. So if you really want to publish loads of papers, don't ever do interventions. If you want to be effective in the world and do things that have meaning, then try it. And I think actually it will totally change the way you think about the work that you do. So in 2003, I started in congenital heart surgery, and we were putting cameras in the operating room to start trying to look at some of these things. Or to look at, no, I'll tell you what. I was told, hey, there you go, you're a human factors, do some of your human factors stuff and go and find some errors. Now, congenital heart surgery is probably the most complex type of high-risk surgery that you can get. It often, the sort of classic surgery here is called the arterial switch operation. You take a 10-day-old baby who has a congenital abnormality where the aorta and the pulmonary vein, I think, are congenitally swapped over. So normally you have blood that's pumped from the heart to the lungs, back to the heart, and then to the body, and then back to the heart, and then back to the lungs. These kids have blood that's pumped to the lungs, and then back to the lungs, and then a separate circuit where the blood is pumped from where the blood is from the heart to the body, and back to the heart again. The only way that they've survived up till this point is because they've probably got a hole in the heart that allows the mixing of oxygenated and non-oxygenated blood. 30 years ago, this was absolutely fatal at 6 months. Now, what we've got is what's called the arterial switch operation. You take a 10-day-old baby, you do a midline sternotomy, which is cutting down down through their breastbone. You put them on cardiopulmonary bypass, so you can then open up the heart. Well, firstly, what you do is you snip the two veins. Snip the two arteries, swap them over. There's actually extra complications to doing that, but I won't go into that. And then you close the hole in the heart. You take them off bypass, you sew everything up, and you ship them out to the ICU. And it's about, depending on where you go, 2 to 5% mortality now. So we've gone from, so this is the amazing thing about healthcare, is that we now have a condition like this, which 30 years ago was, as the phrase is, not compatible with life. And now we have this surgery that, even though it's complex and resource intensive and challenging for everyone involved, we can have these babies have basically a normal life. So we were interested in what might go wrong in these things. So if you start counting all the little things that go wrong, I talked, at the start I had, the equipment wasn't working, and somebody said, there was a miscommunication. You can quickly, well, I say quickly, eventually I got to this idea that, hold on, there are all these little things that are going wrong all the time that might tell us something about how the system works. It might tell us, for example, how reliant we are on communication and coordination, but how it's failing for us. But actually, things like fatigue, at least from an observable point of view, is not a huge problem. Now, that's not to say that it isn't a problem, but in terms of observing the little things that go wrong, fatigue doesn't play a big part. In the middle, this is actually, anyway, I'm not going to go into that too much because I've got better at trying to define how to do this. But this is starting to say, right, what is going wrong? What is giving these people a hard time? What's preventing them from doing their best job? The idea here is that if you watch 20 operations and put together the best 20, the best pieces of each of those 20, you will have a perfect operation. But actually, not any one of those 20 is going to be perfect. There's going to be these little hiccups all the way along. So this is how it sort of so the other thing I could do with this was I had these videos. And it just so happened in these high-risk surgeries, there are a number of events where things really started to go wrong in a bad way. This is one of them. An exsanguination, that means draining the blood out of somebody. Healthcare is very tribal. It has all these really fancy words for stuff because if you can use those words in a way, then you're part of the club. So you could easily say this is draining the blood out of somebody, but actually, high blood pressure and low blood pressure rather than hypertension and hypotension. In fact, you've got to wonder whether hyper and hypo is, leads to confusions. But the point is that part of working in this area is being able to understand the language that they use. At this part of the operation, which was one of these, I think it was probably an arterial switch or something like it, what they do is at the end of, when they've nearly finished with the operation, what they'll do, the blood has all sorts of, they've put liquid into it. And anyway, to concentrate the blood, which is a measure called hematocrit somewhere, which is this figure here, what they do is they reverse the perfusion pump. Usually what happens is they put in blood through the aortic cannula and they take it out of the atrial appendage. Now in what they call modified ultrafiltration, to concentrate the blood, they'll reverse the pump, they'll take a small amount of blood out of the aorta and and treat it with, filter it within the perfusion machine, and then put it back into a line in the atrial appendage. And so this is managed between the perfusionist, the anesthesiologist, and the surgeon. So this is the perfusionist who says, right, filtration stopped. Because why he said that was they'd organised beforehand, we're going to hemofilter to a hematocrit of 40. So at this point, the perfusionist says, right, I've stopped filtering. The anesthesiologist says, what's the hematocrit? Perfusionist says, 40. That's what we agreed. Then the anesthesiologist to the perfusionist says, I think we ought to continue because actually, we're doing quite well here. We can maybe raise the hematocrit some more, and there is a relationship between the recovery of these patients and the hematocrit. So the anesthesiologist is thinking, I think we can do better for this kid. Unfortunately, and the way the operating room is laid out, you've got the anesthesiologist there, the perfusionist there, you've got the resident there, and over the other side of the operating table, you've got the surgeon. Now, the surgeon doesn't hear the conversation that the anesthesiologist and the perfusionist have had about hematocrit. All he's heard is filtration stopped. So he takes the line out of the atrial appendage that's putting blood back into the patient. So at this point, blood is being taken out of the patient and not being put back in. It's not what you want, really. Patients do die from exsanguinations every year. It's relatively rare, but it happens. I don't quite know why, I've never had the opportunity to look into specifically how it happens, and I think, anyway. But you can see how it might happen. So then they're doing other things, and eventually the surgeon says, oh, yeah, by the way, I took the muff line out. And the perfusionist says, well, that's funny, because we're still filtering. They realize that there's a problem. They correct it, and everything's fine. The perfusionist will say, yeah, well, we've got alarms for that should prevent us doing this. And that's fine. Maybe this wouldn't have killed the patient. But clearly it's in a state that we got into that we didn't want to get into. And it tells us something about what's going on. It tells us that there's an enormous amount of complex things to do with goals, things to do with equipment, things to do with shared information, and particularly this shared task between anesthesia, perfusion, and surgery. So this is a sort of, again, I've made this up. This is really what a cardiac operating team kind of looks like. And the arrows, they sort of represent, in my little way, the relationships between them. So the surgeon, the two assistant surgeons as trainees, they do exactly what the surgeon says. The scrub nurse does what the surgeon says or supports them. A really good scrub nurse already knows what the surgeon wants before they ask for it. And then the runner here is helping the scrub nurse. So she or he, it's often a she, but she or he will be supporting the scrub nurse and be, and so that's that. Then you've got the surgeon, the anesthesiologist. Okay, so the anesthesiologist might have a resident or a CRNA, a registered nurse anaesthetist in the US. And so this person does what the anesthesiologist says. But here you've got this triangle. You've got the surgeon, the anesthesiologist, and the perfusionist. And perfusion is managed between these. And there's sort of information that's always going between them all the time at different, it changes at different points. Sometimes the anesthesiologist, when they're on bypass, isn't involved. But at the really critical times when we're going on bypass and off bypass, it's managed across these things. Now, surgeons and anesthesiologists are attendings. And one thing to know about surgeons and anesthesiologists is there's a tension between them. That there's a professional tension between them. The joke is that it's the blood-brain barrier. So the anesthesiologist's work is cognitive, and the surgeon's work is, in orthopedics, the surgeon's work is like this. This person's a technician. They don't have a medical degree. They're specifically trained in perfusion. Now, you've got two professionals who don't like to challenge each other and are, sort of equal status, and one who's not, who's a technician. Who do you think gets the blame when anything goes wrong? Actually, yeah, mostly. Now, actually, I've seen there was one team I worked with who had the surgeon and the perfusionist had worked together for a long time. The perfusionist was, this incredibly tall, really powerful, physically powerful guy, very testosterone-y, and so he used to. The story was, and I never saw this, but the story was that these two would gang up on the anesthesiologist. But the point here is that this is sort of loading the bases, that you can see how, with all these sort of things that are going on, how this complex balance of tasks might go wrong. The sort of thing that will happen is the anesthesiologist will give vasodilators, which basically dilate send all the blood to the skin. I don't, presumably to manage blood pressure, I'm not entirely sure why, but then the perfusionist, to keep the same perfusion pressure in the brain, to keep the same blood flow to the brain, will raise the perfusion pressure on the perfusion machine. Now, what that means is that the blood might not suddenly be draining as well out of here and back into the perfusion machine from the surgical site. So the surgical site fills up, and the surgeon stamping his feet, saying, "You perfusionists, you're not keeping my surgical field clear." And the perfusionist is like, "Well, I'm trying to, but the anesthesiologist has just given these vasodilators and has gone out of the room." So those are the sorts of things that can happen in this relationship. Anyway, so. I'm so behind time. All right. Okay, I'll quickly go through this one. So this is the only time I've ever seen an attending overruled. This was a very senior resident, we call them registrars in the UK, who was doing the sternotomy it was a redo, so it was a kid who'd had an operation before. There's a small chance that in doing this, when you do the sternotomy, which is a sort of bone saw through there, that you'll make a hole in the aorta with these sorts of kids. And this is what happened. So the resident registrar put his thumb on the hole, as you would do, and said, "Right, I need the surgeon and the anesthesiologist right now." It wasn't the attending, it was the resident anesthesiologist who was in the room. So he did, he's doing the right thing. He's like, "Right, I need some help now." Fortunately, both the attendings, in the UK we call them consultants, both of them arrived pretty quickly. But in that time, the hole was getting bigger and the problem was getting bigger. And so what you would do in this situation is you'd ask for heparin, which is the drug, an anticoagulant, which allows you to get on bypass. I have a whole thing that I'm not going to talk to you today about heparin and how that can get into trouble with that. But the assistant says, "I need heparin," because the implication being that we need to get this patient on bypass because things are going south really quickly. But the surgeon, who's the attending surgeon, says, "No, don't give heparin. I'm going to come and save the day," and went to scrub up to get ready. Now, in that time, heart rate, arterial pressure, central venous pressure, oxygen saturation, and end-tidal CO2 had all fallen. Stuff was going wrong with this patient really quickly. So, seeing this, the assistant surgeon again says to the anesthesiologist, "I need some heparin," even though he knows he's just been told, for his boss, don't give heparin. The anesthesiologist looks and says, "Yep, you're right. We need to give heparin right now." And the protocol is that this is announced. So the anesthesiologist says, "Right, we're giving heparin." The surgeon comes in, says, "I said give no heparin." And then he sees what's going on and he's like, "Oh, this is much more serious than I thought." So really, that was the way in which the resident really cleverly saved the day by using his assertion with the senior anesthesiologist. It was really, really, really awesome. And I don't know how many people would do that. This guy was actually an exceptional surgeon. I don't know where he is. Anyway, so there's a lot of these types of things that I saw when I was doing a lot of hanging around in operating rooms that I could talk at great length and great boredom about. The point here is that there's no record of them apart from what I've made of them, because this stuff. Oh, sorry, that particular incident I talked about with the patient nearly bleeding to death made 3 words on the operating note. So this is a problem with doing research in this area. Most of this stuff is not reported, and this is still the case. In fact, it's better in the UK than it is in the US, because in the US, hospitals are absolutely paranoid because of their business models around letting any of this information escape. Any of it, including, anyway. But the nice thing is that over then the subsequent years, there's been a lot of people who have started to do this, to go into operating rooms to see work as done, rather than work as imagined. And so there's a huge amount of stuff and a whole, of people trying to do this, of trying to look at how the systems are working and look at things like, right. Can I have some guidance on, I'm really behind with what I wanted to say, but I think I should go on for a little bit. Is that right? That's fine. Okay. I'm going to skip that. So, so part of what I was trying to do is look at teamwork, because, that was the first thing to look at. Clearly, there are lots of team issues within this type of surgery, and indeed, seem to have lost a slide from here. Anyway, and indeed start to look at interventions to say, does team training work? And I think we did one of the first behavioral observational studies of training operating teams to think about teamwork. I think it was one of the first ever. Trying to do the science around this that says, firstly that teamwork's important, then secondly, actually, we can train it and it might have some effect on those all-important patient outcomes. And indeed, there's a whole swathe of literature now on this that says this is worthwhile doing. This is a systematic review we did. This is a really a great one. And this is also crossed over into the clinical literature. Now, this is Circulation, which is a big cardiac journal. And so it was sort of very important that this sort of thing was being talked about, at least in clinical terms. This is a meta-analysis that was published, I think, a couple of years ago. I have some issues with this, not because it's a bad meta-analysis, but because I don't believe that you can wheel an operating, wheel a surgical team, into a training room, give them 3 hours of training, and then suddenly all their teamwork will get better and all their outcomes will improve, which is the implication of this. If you actually look, anyway, but that's a discussion that we can have a little later. The other issue, one of the particular issues is, I've talked about teamwork in cardiac surgery. The teamwork in orthopedic surgery is hugely different. There's almost no need for the anesthesiologist and the surgeon to communicate. The anesthesiologist is there to keep the patient stable. And what the surgeon's doing, working on the knee, has not much to do with what the anesthesiologist is doing. So there are only really 2 or 3 points which they need to have any communication. The real issue is having the scrub tech who knows how to use all the equipment. So knee surgery has huge numbers of trays, somewhere between sort of 8 and 14 or 18 trays this size. And so the nurse has got to be shuffling them around to get the right equipment. There are all sorts of jigs and screws and things. It's a much more it's much more like carpentry with all the associated tools you might have with carpentry, rather than sort of the scalpel and suture stuff that's done here. And so having a scrub nurse who knows how to use all that equipment will actually be important for the surgeon. And I've seen scrub nurses who would guide the surgeon in the use of the equipment because the surgeon didn't know. So the key relationship in orthopedic surgery is this relationship here between the scrub tech and the surgeon, and particularly having a scrub tech who knows how the operation works, not just somebody who's there giving the surgeon what they want when they want it, as you see in ER. So moving on, the point I'm starting to get to is that teamwork is sort of framed within, or at least the teamwork skills that become popular in healthcare are framed within a sort of wider system. So thinking about structuring the team in different ways is going to be much, and how the team is structured, roles, who's in charge, thinking about the tasks and their sequence so everyone knows what's going on. All of those things are equally as important, possibly more important, than training people in communication skills. Or sort of crew resource management, which is mostly what the teamwork training in healthcare is based on. And this was, a study that was wonderfully media friendly for me and really sort of cemented my career. It's my one-hit wonder, if there is one, which was about how we went to Ferrari and took what they did in pit stops and said, let's translate that. Let's not do what they do, but let's actually understand why they do it, and then see how we can implement a similar idea within our transfers of these tiny sick babies from surgery to intensive care. But the point about that was that it wasn't just about training, it was about structuring all these different things around it. And I'm going to skip that one. Really, all this is about is saying, if you have a good team, if you have a bad, so this is a number of errors on the task. This is a sort of fairly crude teamwork scale. This is if you've got this is a well-defined process. This is post, where we'd actually define the process. This is a not very well-defined process. This is just sort of how they did it beforehand, which was sort of everyone working it out. So the point here being that if you've got a bad team and no process, if you've got a bad team and process, you'll do much better than a bad team without any sort of process. And if you've got a good team and a good process, you'll do much better than everything. So the point here is that the task and the process are interlinked, that it's not just about the skills, it's about, do we know what we're doing? And is there an accepted way to do things that we're going to work towards? Moving on from that, trying to tidy up the workspace. This was a drugs cupboard. Again, this is an NHS drugs cupboard. Actually, ironically, I've just been looking at cupboards that look exactly like this at a hospital that I might be close to where we are right now. And so simply looking at the workspace and how people work and doing an intervention like that is many times can be more powerful than thinking about teamwork. One of the challenges is that if you're training, one of the challenges actually we had with the teamwork study with the neuro team was that they didn't want to do our teamwork training because they said, why are you training us? That seems like you're blaming us for not being a good team when our administrators can't even give us the right equipment to work with. And this is a frequent thing, which isn't reported in, by the way, any of the papers, because there's a massive publication bias. So if you're trying to train people, but not giving them the right, train people in teamwork and not giving them the right environment in which to be, then you're going to get pushback, and probably it's justified. This is a later study where we're trying to combine teamwork training and sort of systems approaches and look at how they combine more effectively. And this is what we did with trauma care, where we looked at a bunch of different things, combining teamwork and briefings and having shared information and other things, thinking about storage, and looking at the effect of those on ED time and on outcomes. And this is extended into app design. where one of the things that we found with these trauma teams is that the first 5 minutes of any trauma is the pager going off and everyone turning up down in the trauma bay saying, does anyone know anything about this patient? Can we find the nurse who took the call? Is she around? No, I haven't seen her. And then suddenly all these, which is what, so the nurse will get a radio call, they'll send out a page, and then everyone's phoning around. You know, you've got, sorry, this is the emergency department, this is imaging, this is the ORs, this is ICU, this is the trauma team, this is the neuro team, and this is the orthopedic team. So the trauma team turn up down there and everyone's phoning in all these places saying, what's happening to this patient? Is it somebody who's fallen over and just needs a, just needs a pat on the head and told, and some, Tylenol and sent home? Or is this a gunshot wound that we need to get our acting gear? And so there are all these phone calls going on the moment this all happens. There's no sort of structured way to think about distributing the information. So as a result, the first few minutes of a trauma are kind of chaotic. Everyone's trying to work out what's going on. And we can't prepare teams because they don't know what's going on. So we did this little thing with an app where everyone's got shared information it was small amounts of information can give particularly the peripheral, RR, ICU, neuro and ortho consult, much better responses. They know whether they need to drop everything and go or whether everything's fine. And they can see from the sort of chain, it's really just a conversation text, they're going to imaging looks like this, we're going to do this next, we're going to do that next. They can see how that's happening and suddenly they can plan for their work much more. And we got a nice little result from that, which I've sat on for a year and haven't published yet. And then I'm also trying to think about this in robotic surgery, which changes everything again, because the surgeons, let's go back. Anyway, the surgeons are no longer at the operating table, so they can't see what the rest of the operating team can see, and this has implications and creates new ways. I'm also looking at this in image-guided spinal surgery, where actually we find that expert surgeons are better at coordinating the team. It's not just that they know how to use the equipment or do the surgery, but they actually know how to get everyone in the right place to use this device, because it needs a whole team. As soon as you move beyond the individual surgeons to having these big devices that need a whole bunch of people to operate, then a surgical skill becomes coordination. And the expertise in the image-guided tech, who's the tech who specializes in using this sort of thing, is both the coordination and the management of all the devices so that they're in the right place at the right time. This isn't necessarily rocket science, but these are not the things that have been thought about when these devices have been brought into the operating room. We tend to focus on the surgical skills alone and forget about needing to train the teams, all the team members, train all them in the new tasks, think about how communication is affected by all these things, think about how these big devices affect the room size, think about how this affects how we move one patient out and they get the next patient in, or how we clean our instruments, or indeed how we have to make sure suddenly that we've got a whole team who are trained and rostered in robotic surgery or image-guided surgery that we didn't need to before, and indeed how we manage their performance. And this has led to R01 that I'm about to start. So finally, what I think this is about, for me professionally, is a sort of different way to be as a human factors expert, if that's what I am. This is academic, this is applied, this is human factors, this is clinical expertise. These are two continuums, and I'm well open to. So academic is always conducted in work as imagined. We have models, and so it's never quite as the real world is. And clinical expertise is usually ignorant of human factors and socio-technical systems, but human factors are usually ignorant of clinical complexity and opacity, how difficult it is to see how the system works, because we've never worked in systems that weren't engineered before. You can't go to a resource that says this is how this operation is done. This doesn't exist. And so the value to humans is going from this to that. You know, if we want to save lives, we want to apply socio-technical systems theory and and human factors expertise in clinical environments. This is the sort of continuum that we have, and most of the human factors work ends at recommendations, which is where the difficult stuff starts. Because I think there's a whole new profession that actually we're starting, and I can talk about this, which is where we're taking these human factors principles, or these systems, complex systems principles, or training principles, and working with clinicians to apply them in clinical contexts. Because sitting back and sort of working from theoretical models is good, is necessary, but not sufficient. So that's where I am going to end, and I'm terribly sorry for going over time. Thank you so much.
Questions?
Oh dear.
So it seems like in the work as imagined and work as done space that you're working with these surgeons and physicians, that there's some lack of self-awareness, and they can't see past what they're doing to see the things that you're trying to point out to them. So how do you sell them on these solutions or get them on board, and do you run into struggles with that, and how do you work?
Oh, totally. No, I've been telling the story. One of my stories, and I have many, many stories about this. I was doing some observations in a surgery once, and the surgeon says, "All right, what are you doing here?" And I said, "Well, I'm, looking at teamwork and process, trying to think about safety." And he said, "Oh, so have you done anything useful recently?" Yeah, and that's, and the way to look at that is that, well, at least they're being upfront about, because there's enormous amount of people who think this is garbage. So what I've done is I know how to engage these people. I know how to talk to them in their own language, and I know how to point out things to them that they're aware of, but they don't necessarily know anyone else is. So the way to get a surgeon engaged is to talk about preference cards. So you can get any surgeon in the world to roll their eyes if you talk about preference cards. Preference cards are the cards that they write out when they say, "I'm going to do this surgery, and this is the equipment that I need to do this surgery." It's always wrong. It's a constant source of frustration, not always, but it's a constant source of frustration for them. And you would think that it would be relatively simple to get the right equipment into a surgery. Actually, it turns out to be incredibly complex. So, I've sort of had to work on that, and part of it is being resilient, particularly early on when I didn't have any of these answers. But nowadays, it's like, oh, okay, I've seen this before. I've got a way in which I can address that. And the most important thing is having a dialogue. When you're making change in any sort of system, what you want is, the people who say, "That's a great idea," are nice. They massage your ego, but they don't tell you anything you don't know already. If you're doing an intervention, of course you know it's a great idea. That's why you're doing it. What you want is for people to say, "No, that's rubbish. That's garbage. That's not going to work." 50% of the time, that'll be just because people are resistant to change. The other 50% of the time, I say 50%, the other proportion of the time is that they will be telling you something you didn't know already. And there's an opportunity there to listen to them and adapt your intervention so it will be successful. And by far the most important thing is not losing the dialogue. So if you have somebody who say, yeah, that's rubbish, what you're doing is garbage. Okay, tell me why it is. Tell me, oh, that's interesting. Yeah, no, and just having those conversations. Yeah, that's why I think that it actually requires, and that, this is, I think, why it requires a whole different set of skills than we would normally recognise within, sort of work science.
Earlier you talked about design solutions and how they covered like the on and off switch with like a plastic cover, but is that still an issue today, or have most of those things been
I don't know about that particular one, but I know that there are all sorts of devices all the time, new ones and old ones, because a lot of these devices won't be replaced for 10, 15, sometimes longer years. And so I'm not sure about that particular issue. I suspect it's still out there. The FDA in 2012 changed their requirements to require more human factors sort of analysis within them. But, and so I think we've yet to see the impact of that. Also, it's kind of limited and has ended up being a tick box exercise for the manufacturers wanting to sell their devices. So I'm not sure. And by the way, the people doing the designing are also workers imagined. They don't have often the opportunity to see the complexity in the ways in which these devices are going to be used and generate use cases that are going to be representative of, for testing. So there's been progress, but yeah, we'll see. The fundamental problem with those is that it's just so difficult to get any information because clinicians blame it on themselves. The same we've got with the electronic health records, which in many ways are disastrous. Been really, really badly designed, and I'm sure have led to all sorts of, well, I know have led to all sorts of accidents. And yet revealing that is really tricky.
Do you have an opinion on the integration of AI in the medical field?
So I'm a natural Luddite. Generally, I'm very skeptical of the claims made by technology. So that's number one. Number two, I think that I think it might be useful in certain situations. I don't know what those are, and they tend to be based on having data, and that relies on the data being put in, which it's often not. And I think finally, I think they're designed on a relatively simplistic premise. Every patient is different. And so having an AI that says, you should do this for this patient, that might be based on not suspect data, and anyway, I'm skeptical. Not that it can't help in certain situations, but if we can't, I think even getting cars to drive themselves effectively is a much greater challenge than the people selling those ideas have thought. And healthcare is so vastly more complex than that. That I mean, indescribably more complex than driving a car. That yeah, we'll see.
So you touched on how in some situations you've seen that checklists can be effective in healthcare, in some situations not so much. Could you elaborate on what factors may determine the effectiveness?
So I didn't get to talk about that. I wrote a paper about this 2 years ago. The way, in fact, I go around with my checklist from an A319, which it only bears a cursory relationship to the checklist in healthcare. For example, the checklist. So a checklist in A319 is essentially a bunch of tasks that are checked off. Have we got the gear down? Yes. Have we contacted air traffic control? Yes. Have we armed the speed brakes? Yes. The healthcare checklist is, have we talked about the patient, and have we, do we know the names of the people? And so they fundamentally rely on teamwork. And so they might work where you have a team who are already functioning well together, but they won't work where you have a team who aren't functioning well together. So the sorts of things that will happen is that the surgeon will come in and say, hey, have you done the checklist yet? what do you mean you haven't done it? I thought, you know, I asked you to do it, and so you don't waste my time. Or the surgeon will say, yeah, yeah, I've done the checklist. Yeah, that's, yeah. So it's in the, so part of it is about the design and the way it's been translated, and partly it's about then people understanding how it's used. Yeah, oh, sorry, yeah.
So in a lot of the diagrams you showed, there was sort of a clear leader or like point, right? Usually it's a surgeon. So I'm wondering, to what extent have you looked at kind of more leadership explicitly, or leadership behaviors in those surgeons, predicting like teamwork?
Yeah, so there has been some interesting work in this, and surgeons love to be leaders. Actually, the truth is that a lot of their time, they've got their head down a dark red hole and have no idea about what else is going on in the operating room. So they are ostensibly the leaders, and they love to be the leaders, and the truth is that if something goes wrong, it comes down to them. But actually, at some points, nurses will be leaders, and at other points, anesthesiologists will be leaders. One of the slides that I didn't show, which was actually, you know, it's not a result that I would stake my limited reputation on, but it's we did a study that looked at the leadership of different groups, and one of the things we found there is in certain types of surgery, the surgeon will wanting to be pushed forward with the operation, and the anesthesiologist will want to slow it down. And so the stronger leaders, anesthesiology leaders in those operations, will be slightly slower. This is actually to do with an operation called a carotid endarterectomy, where, anyway, it doesn't matter, but the point here is that what they'll do is they have to put a cross clamp on the carotid artery, and to do that effectively so you don't get an embolism, you have to give heparin. And the anesthesiologist's job is to give heparin and then wait for 2 minutes for the heparin to act before the surgeon starts. And so this is 2 minutes where the surgeon's got to do nothing, and they hate that. So they're like, right, come on, get on with it, let's, come on, are we ready yet? And so a weak anesthesiologist will let the surgeon progress, and a strong leader anesthesiologist will say, no, just wait, we haven't let the heparin, work yet. So, it's kind of speculative, and I can send you the paper and stuff. I think there's some truth in that. One of the things actually I ask is, anyway, no. Yeah, I will say it. One of the things that interests me is why, is anesthesiologists are clinicians, and they have incredible experience with all sorts of different types of operations. What I don't, and most of the time in the operation they're doing nothing. What I don't understand is why we can't have an anesthesiologist working with the surgeon as a second pair of eyes, saying, hey, have you forgotten that? Or hey, have you done that? Or just making sure you've done that. Now, they would hate it. The surgeons would absolutely hate it. But here you've got actually a resource that you're not using to the full extent it could be used. And it would get the anesthesiologist engaged and all that. But I think that would be difficult culturally.
One last question.
So I think what you're talking about hits on, I'm really interested in the intersection of like communication errors arising from a combination of motivation issues and hierarchy.
Mm-hmm.
So medicine's very hierarchical.
Mm-hmm.
Another example would be the military is very hierarchical.
Mm-hmm.
But if you don't listen to the rest of your troops on the ground, you're all going to die, and it changes the emphasis on communication. So I'm curious if you've seen interventions that like help deconstruct some of that hierarchy or help physicians reframe so that they understand the motivation more personally? Because I understand that like if someone dies, it's a huge amount of guilt, but it's different than them being on the table. At the end of the day, everyone walks away.
Yeah, so I have two thoughts about that. One of which is there's been quite a interesting emphasis, I don't know whether you know this, on teaching nurses to speak up.
Yes.
Yep, so you come across this. So, the standard thing in team steps, which I didn't mention, which is the sort of the stand, anyway, it's, they call it CUS. So you challenge. Anyway, so it's a sort of staged thing. Is that what you're doing? Are you really doing that? No, I think you should stop. No, absolutely you have to stop. So you don't, so, you know, the idea is that you can train people to speak up in that way, and sort of this sort of escalation mechanism, and train potentially the physicians to hear that being said to them. Of course, what happens is the nurses get trained, but the physicians don't, because it doesn't apply to them. Now, the other way to think about this, or the other way I've thought about this, is that is in terms of lowering the hierarchy. And so, at a hospital I was at once, you know, not the one I'm at now, they'd done all this training and training nurses to speak up. And I said, oh, well, did you do anything with the physicians about first names? Because in Australia, everyone calls each other by their first names. In England, it varies. Sometimes it's Dr. So-and-so, sometimes it's, you know, it's Ken. In the US, it's all Doctor this, Doctor that, which I think is, you know, I think it's all about ego and nothing about anything else. And it's all about ego and hierarchy. And so I said, well, you know, did you, you know, as well as training nurses to speak up, did you actually do anything about lowering the hierarchy with encouraging physicians to use first names? Because, you know, I think there may be evidence that this is effective. Oh no, we didn't do that. We tried it, but the physicians didn't want it, so we just gave up. And so that's, you know, that's, yeah, which is a little bit, I guess it's a little bit cynical, but, you know, those are some of the challenges that we have. Yeah, I would love to see first names, and I think that would be really effective at reducing the hierarchy, but I really don't see it happening. I don't know, and I can't, yeah, I can't, yeah.
Ken, thank you very much. We have a reception outside, but let's thank him for...
Thank you so much. Yeah.